Okay, thank you. Welcome, everyone. Thank you for joining us. The Global Health Institute, in partnership with MESCOP Global Health Programs and the Global Health Alliance, is excited to welcome you to the Global Health Speaker Series, showcasing the multidisciplinary aspects of global health work and research. I will hand it off to our student, a previous speaker and member of the Global Health Alliance, Priyanka Ravi, who has the honor of presenting today's guest speaker.
Thank you, Roxana. Good afternoon, everyone. I'm Priyanka Ravi, a PhD student and member of the Global Health Alliance, a student-driven organization aimed to enhance students' knowledge of how public health functions in a global context. I'm excited to partner with Global Health Institute to introduce today's speaker. Dr. Randy Waechter is an associate professor in the School of Medicine, assistant dean in the School of Graduate Studies, and associate director of research at St. George's University in Grenada, West Indies. He teaches research ethics, develops and oversees graduate degree programs, and oversees all research activities at the Institute. He is a cognitive neuroscientist by training and has been conducting global health research on infectious diseases and child neurodevelopment from within LMICs for more than 10 years. He also implements and examines the effectiveness of social, emotional interventions in early childhood on mental health across the lifespan. Please join me in welcoming Dr. Waechter as he presents the Global Health Research Ethics Lessons from Within a LMIC. Welcome, Dr. Waechter. The floor is yours.
Thank you very much, Priyanka. It's a pleasure to be here with you all, and thank you to the College of Public Health, Global Health Institute, and to Dr. Madhivanan, who invited me to come and speak with you all today. I'll just share my screen. I've got a few slides, but I promise that I'm not going to have lots and lots of words. There are some wordy slides, but not too many, hopefully. And what I'd like to do is really get you all to follow me as I walk through a narrative of, first of all, laying down the foundation for global health research and what it means when we're talking about global health research. And then we'll tie in specifically ethics and some of the challenges associated with taking a global perspective when we're looking at carrying out a research, and how we can address some of those challenges. And so I'm going to start you off with a quote, and this is one of my favorite physicians and philosophers, Albert Schweitzer. He lived from 1875 to 1965, and he was an Alsatian German French theologian. My ancestors are from the Alsace region, so it's and has particular meaning for me from that perspective. But he's an interesting guy because he was multi-talented. So he was an organist, a theologian, a humanitarian, a writer, a philosopher, and he was also a physician. He was also an anti-colonialist who opened a hospital in Labarane, Gabon, where he practiced his philosophy about reverence for life. And for that work that he wrote, he received the Nobel Peace Prize in 1952. So what is this idea that Albert Schweitzer had, this reverence for life? Well, it's this idea that the only thing that each of us are really sure of is that we live and we want to go on living as long as possible. And this is something we share in common with everything else that lives, from blue whales to single-celled organisms, and of course, every other human being. We are thus connected to all living things. We owe to all of them the same care and respect that we wish for ourselves. And in this way, reverence for life exhibits similarities, of course, to the golden rule. Now, the essential element in civilization or civilized societies is this process of ethical perfecting of the individual as well as society and the individual within society. And so the will of the civilization then is this universal will to progress, and that is this conscious process of incorporating ethics to attain the highest value. So in spite of the great importance we attach to achievements of science and human prowess. It is really humanity that is striving for ethical ends that can benefit in full measure from the material progress, but need to overcome the focus on material progress for the sake of material progress. And so for Schweitzer, the only possible way out of this trap, this chaos, if you will, is to adopt a concept of the world based on this ideal of true civilization, which is based on this ideal of ethics and reverence for life. Now, Schweitzer was a theologian. He studied numerous religions, including Asian and Indian religions, to really come up with his personal philosophy of ethics. In that study, he found that none of them quite addressed the issue in its entirety. So he continued to search, and that's where he came up with his own solution. But his reverence for life philosophy acknowledges the fundamental tensions in ethics that require mindfulness, deep reflection, and the search for continual balance. And so in this philosophy, he came to appreciate the dynamic tension and the need to continually strive for the ideal balance through self-awareness and reflection. So there's a quote that he gave: in nature, one form of life must always prey upon another. However, human consciousness holds an awareness of and sympathy for the will of other beings to live, this reverence for life. An ethical human strives to escape from this contradiction so far as possible. So Schweitzer recognized that it isn't about perfection. All great philosophers and prophets have understood that perfection is an illusion. Instead, it's about striving for perfection. It's about the continual process of reflection and refinement. And as such, ethics is not a checkbox or a point along the pathway of research, but rather a continual process. Ethics is the journey, not points along the journey. And that's something that we as global health researchers need to keep in mind. Now, central also to Schweitzer's philosophy is that we are all individual while simultaneously being connected with all other humans, all other living creatures, and the environment. And this is also the foundation of ethics and global health. And in fact, the root of all the current challenges humanity is facing. So we are at this point in human history where we can no longer think from an individualistic perspective. Worrying only about yourself and the welfare of your tribe of 75 or 100 people wasn't a major problem 10,000 years ago or 7 or 8,000 years ago, when there were only 4 or 5 million people on the entire planet. Worrying about yourself, only about yourself and the members of your extended family, is a major problem when there are now 8 billion people on the planet, and on our way to 10 billion people on the planet. And so the mindset of every person must shift more to the collective if we're going to get through the unprecedented collective challenges that we now face in our global environment. And we saw this coming, right? So this is not a shocker. This is not a surprise. So think of the tragedy of the commons, right? So in economics and in ecological context, this tragedy of the commons is at that situation in which individual users who have open access to a resource unhampered by shared social structures or formal rules that govern access and use, when they act independently according to their own self-interest and contrary to the common good of all users, end up causing depletion of the resource through their uncoordinated action in case there are too many users related to the available resources. And so this is a central element of the concept, or actually originated in an essay written in 1833 by the British economist William Forster Lloyd, who used a hypothetical example of the effects of unregulated grazing on common land, also known as the commons in Anglo-Saxon law in Great Britain and Ireland. And so the theory became widely known as the tragedy of the commons after an essay with this title was written by Garrett Hardin and published in the journal Science in 1968. This article actually became one of the most cited academic papers published. I just checked it today. It has over 51,000 citations, that article. So all those in academia, that's an impressive citation count by any metric. And so this concept of the tragedy of the commons, where if we don't coordinate our efforts, then individuals looking after their own self-interests can quickly overwhelm the common resources that are out there for all to share, can become a real problem. So this idea of the tragedy of the commons also ties directly into Schweitzer's recognition that we are all individuals whose fates are tied to each other. So to avoid the tragedy of the unmanaged commons, we must work to ensure that all people, and indeed all living things, are respected and cared for. And that's where the idea of global health addresses the health of disadvantaged populations, regardless of where they live, while acknowledging the importance of equity for health and well-being. This has been defined as public health everywhere. It has also been defined as health for all, driven by equity principles, health by all, influenced and improved by a broad scope of actors, and health in all. When we talk about health in all policies, and we talk about governments who are deriving their financial policies, education policies, healthcare policies, transportation policies, trading policies, while keeping the thread of health for the population, and specifically health and well-being for the population, embedded in the process of making decisions across those different portfolios. And that is where this concept of health in all policies really comes from. Now, remember, public health is the early diagnosis and or prevention of disease, the prolonging of life, and promotion of physical health through sanitation of the environment or control of communicable infections, and or the education of the individual. Public health, from that definition, is closely related to global health, but it differs in scope. So whereas public health professionals are charged with the health of prescribed populations within a city, a state, or region, or nation, global health professionals address healthcare challenges and policies across national borders. And so this is especially important in addressing things like infectious diseases or climate-related health concerns, because, of course, pathogens, as we have learned quite well recently with the SARS-CoV-2 pandemic, and carbon that we emit into the atmosphere when we run a coal-fired power plant or an internal combustion engine automobile, simply don't respect the borders that human beings have created. Right? These are artificial concepts created by societies and by individuals. Viruses don't care about our borders. A carbon molecule emitted into the atmosphere certainly doesn't care about our borders. And so there are certain areas of health work that we engage in that by necessity are global, when there are no boundaries that we can really speak of. Now, understanding global health ethics also requires one to acknowledge factors that influence enormous inequalities in global health. And there are many historical and geographic reasons for the existence of these disparities that have been laid out in detail by Jared Diamond in his excellent volume, Guns, Germs, and Steel, for example, among other sources. And as a result of that history, we see ongoing economic disparities, extreme poverty, limits on human rights, political repression, and the 90-10 gap, wherein 90% of global research dollars are spent on health problems that affect only 10% of the world's population. According to the World Bank, 8.4%, or about 645 million people, mostly in tropical developing regions around the world, lived in poverty in 2019. These people don't have access to some of the very basic necessities of life: reliable shelter, clean water, nutritious food, healthcare. And so improving access to those basic necessities significantly impacts health and quality of life. And that draws directly in from this realization that in public health, the greatest advances that we've seen in the field itself of public health have come from improvements in sanitation, right? So providing clean water has saved more lives than I'm willing to bet all the actions of all the physicians that have ever lived. Providing the safe production and storage and transportation of food, thereby preventing microbial growth and infection, I'm sure has saved countless lives. And so in order to have those levels of sanitation, flushing toilets, clean water that is distributed in a safe manner, um, protection from the elements, you need to have a very basic level of economic development. And so that global health and the health of populations is directly tied to economic development. And so we as global health researchers need to acknowledge that very close connection, and need to understand that when we're trying to address issues of health around the globe, we're also by necessity hoping or needing to address those economic disparities. So global health requires an acknowledgement of and attempts to address socioeconomic inequities. And when global health researchers are working across these international boundaries, they recognize and acknowledge the significance of those disparities, and understand, or should try to understand, what those disparities are in the particular region that they're working, so that they have a better understanding of the drivers that can impact the health of the populations in those regions. Now, in a perfect world, all individuals would possess roughly equivalent levels of power. But since it's just not the world we live in, and if it is possible, is some distance in the future, we must clearly define the parameters of how those with greater power should interact with those who have lesser power. And so this takes us back to Schweitzer's concept of, or recognition of the importance of mindfulness, right? Of awareness, of self-reflection. So we as global health researchers need to understand that we are probably in a privileged position. We probably have power over many of those that we would be working with in the places where we're working. And that's the first step in trying our best to address that power differential, or at least work around the power differential as best we can. Now, when we talk about ethics, we just want to make a distinction between ethics and laws, right? So laws are rules that direct behavior within a society, whereas ethical guidelines are less formal than laws or rules, and are more widely applicable. And the ethical guidelines are there to help us to decide how we analyze complex problems and issues, and how we move forward. And so it's a gateway into deliberate thoughts, deliberate action, and it's a guidebook, if you will, for how to think through, first of all, become aware of, and then think through and work through those potential conflicts that might arise. So ethical principles. Now, I'm sure you all have heard of these before, but it's worth taking a moment to just review them. So 3 fundamental principles of ethics that have arisen, that arose in the second half of the 20th century. Respect for persons is another way of saying respect for autonomy, which aligns with Schweitzer's concept of reverence for life. So every person is separate and unique, a separate entity who wishes to think about and realize self-determination by making decisions about their own life. Now, if you don't believe me that everybody wishes to direct their own actions, to set their own goals, to work towards their goals, to achieve their goals, obviously hasn't spent time with a 2-year-old, right? So at that developmental age, right, children are absolutely preoccupied with gaining autonomy and doing things for themselves. Like, I do it, right? And so it's this ingrained cognitive system that really drives autonomy, and certainly all humans have it. Animals have it as well, and it makes sense because in order to survive the environment, in order for our genes to propagate themselves, and that is what the genes are trying to do. That's driving all of our behavior. The genes we're a fancy package for our genes. They propagate to the next generation by driving our behavior through genetic coding and through the development and evolution of our phenotype, our body structure, and the way that our minds work as a part of our body over time. And so this respect for autonomy, this respect for the individuality of people and their desire to drive their own behaviors and make their own decisions is deeply embedded in our ethics. And so for me, it's a biologically based principle of ethics, right? So we're actually looking at how does the brain work? How does biology and evolution and inherit and genetics drive behavior? And we're saying, yeah, this is a fundamental principle of life. And so we need to acknowledge that and we need to work with it. And that is what Schweitzer recognized as well in his philosophy of reverence for life. Now, then the second principle is beneficence, and this is the principle of doing good. And it's directly tied to the concept of non-maleficence, which is the avoidance of doing harm. So you could think of like that yin yang cycle. And at its base level, beneficence is about helping others to achieve maximum positive outcomes or to obtain maximum possible benefits while avoiding harms. And so it's this fundamental principle of let's do good. So what do we mean by that? Well, we know that every person wants to be autonomous and make decisions for themselves. We know that every living thing needs fundamental basic things to survive: clean water, clean air, food, shelter, especially for mammals, social emotional connection, safety. And so let's do what we can to ensure all of those things, and to ensure that all living creatures have access to those things. And that is this concept of doing good, beneficence. And then justice is about, well, who should receive the benefits of the work that we do, the things that we're doing. In this case, we're talking about global health research. So who should receive the benefits of that research, and who should bear its burdens? These are fundamental questions about fairness in distribution and what is deserved. And injustice occurs when some benefit to which a person is entitled is denied without good reason, or when some burden is imposed upon an individual unduly or without good reason. And so this principle is acknowledging that none of us is alone, right? So it's acknowledging that other end of the spectrum, which is, yeah, well, we are all individuals. We are not alone on the planet. We're sharing the environment with others. And we need to acknowledge and be mindful of that. And we need to work to ensure that we're not impinging on the autonomy of other individuals, right? So we're respecting autonomy of each individual, And we're ensuring that as a group, as a whole, and you could talk about the entire population of the planet, or you could talk about subgroups of people or subgroups of animals and living things around the planet that are on the planet, to ensure that those subgroups are not unjustly burdened or receive unjust benefits. Now, this is all tied to this concept of decolonization. And it's a very timely topic that is being reflected in popular media over the past several years. And so it behooves us to take a moment or two to think about, well, what is this concept of decolonization and how does it all fit in with global health and global health ethics? Well, according to the United Nations, only 17 non-self-governing territories comprising fewer than 2 million inhabitants remain on Earth. And so if you talk about the term decolonization from the literal perspective of giving people in territories self-rule, that's mostly done or being done. So when we use the term colonization, we're more referring to addressing the ongoing effects of colonization and related forms of exploitation and domination. And so we need to acknowledge that what has happened in the past does have reverberating effects through the future, through the present and the future. It's not to say that we who are living today colonized, but it is to acknowledge that it does have an ongoing impact. And so we want to have open discussion regarding existing power imbalances between high and low income country researchers at both the country and institutional level. And this is a necessary discussion to progress with solutions which meet the needs of all partners and avoid international research groups putting their needs above those of their local partners due to the assumption that they are more knowledgeable. And that can be an unfortunate spillover effect of colonization. And so we sometimes talk about ways of knowing, right? So why is my Western way of knowing necessarily better than other indigenous ways of knowing? And so again, it's that process of reflecting on that potential power differential. Okay, so now we're in a position to talk about some of the ethical considerations specific to global health work. So at the turn of the 21st century, low middle income countries accounted for 85% of the world's population and 92% of the global disease burden, but only about 10% of global health research funding was devoted to addressing persistent challenges within those countries. That is, most global health research is carried out in high income countries, which do not always consider the burden of specific diseases within low middle income countries when allocating their funding. Now, despite a recent push towards equitable access, global disparities in distribution of treatments like vaccines remain. Low middle income countries have limited research, manufacturing, and logistical capacity, like cold chain storage, to discover, produce, and distribute medicines and/or vaccines for infectious diseases within their own countries. Many of those countries rely on the charity of developed nations to provide knowledge and capacity to produce or supply medicines and vaccines. As the SARS-CoV-2 pandemic clearly demonstrated, these LMICs must often wait for wealthy country donations of vaccines, and many had to wait a very long time for adequate supplies of vaccinations or vaccines. Now, to address this, we look at things like the fair benefits framework, and that framework relies on three ethical conditions. So the first is that the research should address a significant health problem within the developing country population. So if I want to carry out research within a developing country, it should be in an area that has been identified as a priority for the people in that country, in that region, for the people on the ground. Secondly, the research objectives should provide strong justification for carrying out the study in any given population, right? So we want to avoid potential exploitation by moving into a particular region to carry out a research study when there is no justification for doing so. So remember the principle of justice and the distribution of burden as well as benefits of research. And thirdly, the benefits to the population must outweigh the risks. So that's that constant balance of, okay, well, there are potential burdens here, there are risks associated with carrying out this study, but the potential rewards, the benefits are much higher in terms of potentially eliminating or treating a significant disease burden among the population. So we build partnerships in order to carry out successful studies in global health work. We want to create and sustain that successful partnership through trust and communication and mutual respect between partners, and defining expectations and roles, while at the same time supporting whatever partner is in the lower power category. Whatever partner has less power, the partner with more power should be working to build capacity to raise that other partner up to a more equal footing. And that in turn then supports trust, good communication, good planning, role expectation, and mutual respect. And so it's kind of like a marriage. So these are all the critical pieces required for a successful marriage, a successful partnership. So on the flip side, what are the obstacles? Well, paternalism. So someone driving the research agenda without open communication and goal building and processing and discussion. Lack of access, inequity in compensation and academic credit, for example. Well, that is not capacity building and empowerment, right? So all the opposite components that we see with successful partnerships. And when it comes to ethical considerations, we have to recognize that there is no international convention or law binding countries to an ethics guideline. Now, some countries have laws, for example, the Code of Federal Regulations and the Common Rule in the United States. But there are fractured review systems. Remember that low middle income countries can lack the capacity, and that includes capacity in research ethics. So that includes capacity in being able to review research projects from the perspective of the low middle income country. We've seen situations of ethics skirting and ethics dumping where developed countries, research organizations, researchers in developed countries purposely go to a low middle income country because the ethics system is not fully developed in that country. And so they think, okay, well, we can get ethics approval to carry out our study in that country, or we actually dump all of the requirements for obtaining ethical approval onto whatever ethical system exists within that country, thereby offloading our duty, our requirement to obtain ethical clearance to the developing country, the low middle income country. And so other challenges that we see, participant payment coercion. So remember that a payment to a research participant in a developed country, if you pay the same amount to a research participant in a developing country, that could be seen as coercive because of the disparities in income. Education level in a developing country might not be the same. And so we want to ensure that our participants can understand the study and the protocols and provide informed consent. We need to understand the cultural differences when we go into a different country. So in the West, we very much prioritize individual autonomy. and decision-making, but in some places, community decision-making is more prioritized. And then accessibility of whatever comes out of the research. So will the participants on the ground in those countries receive the benefits from the research, if any benefits arise? And so we also need to recognize that commercial entities are taking on a bigger role in carrying out research overall, globally. And so Jones, which is the Council for International Organizations of Medical Sciences, CORED, which is the Council on Health Research and Development, have called for sponsors from wealthy countries to consult and engage host country researchers and communities and stakeholders about the challenges that they're experiencing on the ground, and to engage in that dialogue about, well, what is the priority for the community on the ground? And we need to continue providing education for reviewers on the ground so that they can deepen their knowledge about research methods, ongoing challenges in bioethics, and evolving ethical issues, so that they are able to provide oversight and ethical review from their perspective on the ground in the developing country. And there are programs that are starting to address these research ethics capacity issues. So here at St. George's University here in Grenada, we've got an NIH Fogarty funded grant that supports capacity building for research and research ethics by funding training in research ethics. So these projects are being carried out across the Caribbean and South America and the Middle East and Africa and Asia and Southeast Asia. And each of these programs is unique and tailors to the educational approach to the needs of the host country or region. And they're all founded on the mentor-mentee model. And so here we have the Caribbean Research Ethics Education Initiative. We provide a master's degree in bioethics simultaneously to English and Spanish speaking fellows in low resource countries to build that human resource capacity, to build that knowledge in research ethics so that they can go back to their country and provide that research ethics oversight. So here is a case example. So an LMIC researcher wants to carry out an epidemiological and longitudinal study examining the potential impact of maternal vector-borne viral infection on fetal and early child development. Now, in exchange for enrolling in the study, the women want timely feedback on fetal and child development and access to interventions when delays in development are detected. A reasonable request. So what are the potential ethical and methodological challenges that can arise here? Well, first, from a methodological perspective, do we have the ability on the ground where the study is being carried out to accurately measure and determine whether the children are developing normally, especially from a functional perspective? Can the study be designed and carried out in a way that timely feedback can be provided to the women? So can we address their concern, their request? Do resources exist on the ground to actually provide assistance when a child is identified as developmentally delayed? And if that expertise, because often we're looking at engaging with an occupational therapist or some other type of intervention, usually requires high skilled, highly paid professionals. Maybe the funding isn't there, the women can't pay for it, or it doesn't even exist. And if it doesn't exist, then what do we do? Is the funding agency willing to fund interventions for the children who have been identified as developmentally delayed, who might not have been identified if the study hadn't been carried out? will the funding agency provide that money? Well, given the fact that it's a surveillance study, they might say no. This is about collecting information. This study, it's not about providing an intervention. Can the primary aim of the study still be achieved with the limited funding available? And is there a capacity building component to the study associated funding beyond the intervention? So is there some capacity building of the researchers on the ground, for example? Okay. I see a hand. Do you want to ask a question? If you do, please go for it. No?
Jepkush, do you have a question?
Oh, maybe some problems with her mic. Well, why don't I keep going, and you can maybe try and put your question type it out in the chat, and then I'll address it. So we actually ran into a very similar challenge with some work that we were doing on the ground here in the Caribbean region, where we were looking at, of course, we had Zika virus infection, chikungunya virus, and now, of course, SARS-CoV-2. And we wanted to look at that impact on child development. And this is a very much an epidemiological longitudinal type study. And we procured funding to carry out that study. But of course, the women wanted intervention for any children that were identified as being developmentally delayed. The funder was not interested in providing funding for that aspect of the study because it was an epidemiological study. It wasn't an intervention study. And so we partnered with the Ministry of Health. We provided the feedback to the women when there was an identified potential problem with child development. And we tried to provide whatever assistance was available through the Ministry of Health. So that partnership was critically important, but it wasn't ideal. We would have liked to been able to provide more assistance. And that was a real challenge for us as researchers, knowing that we wanted to do more, but the resources were very limited. And I'll give you one more case, and then we'll finish up and I'll open for questions. This is a situation where you've got an international pharmaceutical company. They developed a new drug for treating, reducing the symptoms of dengue. The company partners with a researcher in a low-income country to run a randomized control trial of the new drug versus current first-line drug treatment of choice. What are the potential ethical and methodological challenges in this type of situation? Okay, well, number one, right? If it's a low-income country, do the necessary research ethics oversights infrastructure exist to really examine that study and determine, okay, is this something that's going to be that's going to meet ethical requirements? It's going to maximize benefits, reduce harms. We want to ask the question, why was that particular site chosen to run the study? How much would it cost to run the study in an upper middle income or even an upper income country or location? We want to make sure that that site wasn't just chosen because it's just going to save the pharmaceutical company all sorts of money to run the study in that site. Another question, is an intervention for dengue fever a priority for the community? Given that it's a low-income country, there might be much more urgent and pressing issues that the community would like to address. So has there been any consultation with the community? And if there was, who was driving that consultation? Was it a true back and forth dialogue, trying to determine what the priorities were for the community? And could community leaders make a free and informed decision about getting involved in the study? Will the community be given free access or much reduced cost access to the new drug if it proves effective in addressing dengue fever? And then for how long will that access be provided? Is there any plan for capacity building as part of the research implementation? So are they going to build capacity for research within the community so that the community can start to learn how to engage in its own studies to address the issues that it finds to be a priority. What's the plan for consenting participants? Kind of a more nitty-gritty question. So right away, you can see all sorts of very important questions start to emerge about why is this study being carried out in that community. And we can see that the greater the disparity between, or the power differential between who it is that wants to carry out the study and who is the subject of the study, the more we want to be very careful about what's really going on here in terms of who's making the decisions and who is driving the agenda. And so we've run into situations like that as well on the ground here, where we've had pharmaceutical companies, private corporations who wanted to come in and run studies. One where they wanted to look at genetically modified mosquito release to reduce vector-borne diseases. And so those situations require very careful discussion, consideration, and review by all interested individuals, community representatives, community leaders, to try and really determine, is this, what is the cost benefit balance here, and is this really a study that's going to benefit the community while not placing too much burden on the community? So that principle of justice. And so with that, I will stop here. I just wanted to mention that we've got all of these concepts in an upcoming chapter. The book is called Infectious Disease Work in a Changing World, People, Pathogens, and Partnerships by Desiree Lebeau and Anna Stewart. And thank you to my co-authors, Kareem Kamansingh, Cheryl McPherson, and Samira Sarma. We've put together a chapter on ethical challenges in global health research, and that's where a lot of these ideas for the presentation today came from. So thank you very much. And I'll open the chat and see if we got any questions. Okay, my question, there are also issues with capacity building with credentials that cannot be transferred locally into another job. Are there ethical concerns in that realm? So building credentials that cannot be transferred locally into another job. Can you type some more and tell me a little bit more about what you mean by that? Because I don't want to assume. I want to be sure that I'm understanding correctly. If you're able to type that in. And in the meantime, I'll stop sharing.
Thank you, Dr. Waechter. It was a really wonderful presentation. I think Jeb Coach has more information.
Yes, for example, there is usually HIV counseling. So do you mean when there are issues with capacity building when people, for example, who are credentialed in HIV counseling, they cannot transfer into another job locally based on those credentials, or? Oh.
Hello?
Hi, I can hear you. Yeah. Heard you for a moment.
Hello?
Hi. We got you.
Hello? Okay.
Yeah, we can hear you.
Okay. Okay. Good. For some reason, I don't know what happened between when I said hi and now. But my question was, okay, for example, I used to work in South Africa, and they were providing all this training like HIV counseling and testing to the local community so that they could be able to use it. But then it's not what the Ministry of Health accepts as something that they could use. So all these people flock to this training and to take this job, and then they couldn't use it at all. So like,
Yeah.
so I started to learn about how when we say capacity building, but capacity building only for the work for the study, or is it something that is going to be transferable for them to use?
Yeah, it's a great example. So that's a situation where, and this is a common theme, right? So it's, I'm a researcher from a developed country, and I'm an expert in, say, counseling for HIV. And so I've got this great program and I've done all sorts of research and I've published on it and look at how effective it is and how well it works. And so I, good intention, right? Go into South Africa or another African country and I say, look, I've got money from some organization in the United States or Western Europe, wherever. They're going to give me money to come in and provide this evidence-based training in South Africa. And so I come in, I say, look at this great thing, and I get everybody excited and we go and we do all the training. But I haven't, so go back to the points, right? So I haven't asked the community, what's your priority, right? So is this even an important thing for you? And they might all flock to the, if I'm paying people to take the training, that's like a job, great, I'll come and take your training. Did I communicate with the government and relevant power brokers and leaders? Did I communicate with the relevant medical professionals in the region? Have I built up that partnership? Have I built up the communication to explain, hey, this is what it is I want? And then they respond and say, well, these are our, credentials. These are our priorities. And then how do I work it so that what I'm doing fits with their priorities while I'm respecting their autonomy and how they operate on the ground? And then we come up with a joint program that works for everybody. And it sounds to me like that didn't happen. So then what ends up happening is there's no sustainability. So I go in there and I do my thing and everybody gets trained up, and then the authorities say, what is this? No. And then all these people have these great skills and they can't implement them. So that's, yeah, that totally absolutely fits the narrative with what we see over and over and over again. Thank you for
Yeah.
the question. Yeah.
Yeah, I mean, thank you. I really enjoyed this presentation. It's really great stuff.
Thank you. Any other questions?
Can we invite you to speak to some more students later?
You absolutely can. I'm happy to speak anytime.
Okay.
If it's helpful, sure.
Thank you.
No problem.
I have a question about the participant compensation, because
Mm.
when we do a study in the high income country, the compensation might be higher. And when we do it in a low middle income country, should we keep it the same, or like can it be based on the economy of the country? Because sometimes like I'm from India, so when we used to compensate there, we used to give them the wages because they used to come for the study and they used to lose the wages. So based on that, which would be much lower than the, like, sorry, higher, like to the compensation which is given here, which might be like 3 or 4 times more. So how do we, like, which is the right way to do it?
Yeah, that's a great question. And there really is no right way. It varies depending on the culture and the societal expectations and the societal norms where it is. And so again, that goes back to the critical importance of dialogue between you and community leaders on the ground, taking the time to understand how does it work. So for example, in many places in the Caribbean where we do research, we don't pay participants for participating in our research. We'll cover things like, hey, bus fare or whatever, transportation fees, I think. And that just seems to be the norm, but that might not be appropriate at all in another location. And then also the disparities. So you might say, it sounds like, okay, if we're carrying out research like on the ground in India, we're going to say, look, it's going to take you all day to come here to participate in whatever we want you to do, and then to get back home. And if you have to take a day off work, then you're losing an entire day's wages, plus your transportation fees, whatever. And so it might be very much the norm to say, no, you need to replace whatever that person's losing, whatever they're giving up, to participate in this study. And that might be a relatively high amount, in context. Whereas other places might say, well, no, it's going to be, it's an hour of your time. So here's the hourly wage rate, and this is the average, and we're going to pay that hourly. So whatever it is, you just have to have, a justification for it. And you have to have, again, Schweitzer's concept of it's mindfulness, it's reflection, it's carefully thinking about what it is you want to do, and having a dialogue with others about, hey, is this a good idea? What's your perspective? Am I meeting cultural norms, societal norms on the ground?
Thank you.
Thank you.
What about research dissemination? I just thought about that.
Like as in disseminating the results of the studies?
Yeah, the results of the studies or any type of feedback to the communities. Because there's some studies, man, they would take so many samples. Like they will take samples from every orifice of your body, and then you never hear from them again for years.
Yeah, huge problem. So, and we've run into that as well in the work that we've done on the ground. We've taken blood samples. So, for example, when we were looking at Zika infection and its impact on child neurodevelopment, early child development, we needed to take blood samples from the children and the moms because, of course, we need to know who's been infected with Zika and who hasn't. If we're going to be able to determine, is there an impact for us on the ground here? And so justifiably, and it was a longitudinal study because when you've got an outbreak or a pandemic, it's going over time, right? So I might be negative today, but I might be positive next week. And so you need to take samples over time. And so eventually, of course, the women on the ground were like, well, what are my test results, right? What's going on? And so we had to come up with a way of providing that feedback, but we were working with the clinics on the ground. And so it wasn't appropriate for us to provide medical information directly to the women. We had to work through the clinics with the Ministry of Health, because it's sensitive information about their health. And the Ministry of Health, it's universal public or universal healthcare system. And so we had to think very carefully about how do we partner with the Ministry of Health? What is the process for providing this kind of feedback, these test results? And it was the same thing with the child neurodevelopmental results. And so to do that, we had to think about, okay, we're not providing a full clinical assessment of child neurodevelopment where it's a screening tool. How do we explain that this is a screening tool? It's not necessarily the case that a child is neurodevelopmentally delayed. It's more of a, hey, there is a potential problem here. And so we had to work again with the Ministry of Health to very carefully think about how do we provide that information, and the ethical dilemma of I'm not going to provide that information to a mom saying, look, there's a potential problem here with neurodevelopment in your child, and not provide, okay, well, what does she do next? Right? You don't provide, hey, here's your test. It's like, it would be like you going to the doctor says, hey, here's your test result. Like, you've got X, Y, and Z disease. Okay, have a nice day. Right? How do we provide then the next step for the mom? And again, with the challenges of, well, we don't have funding for that. That's not part of the study. That's not part of what the funder wanted to provide money for. And so how do we solve that problem? Right? How do we find resources to be able to do that follow-up when, we just don't have it? And so that was, again, working very carefully and closely with the Ministry of Health and trying to figure out what is available for moms in that situation.
Yeah, I mean, I understand sometimes there's some gray areas that not a lot of people may understand. I like what, as you said, if I tell you have a potential, what are you going to do about it? Is it necessary to make somebody panic if there's like not immediate interventions that we could do? But that information usually helps people advocate for their health. I find that in a lot of research conducted in some developing countries, that nobody, even if it's a small research and observational study, they don't give a one-page summary or like something that folks in the community can look at and say, okay, well, these studies came by and said this is an actual problem in our community. We need to have these services in our clinics, whether it was even if it's even though even because people in the United States understand not every research is a result or will result in a diagnosis, but it's something that they're looking for, but it's something that they can go and advocate for their own health. And I feel like most folks are not given that opportunity at all. They're like, well, they're just not going to understand, you know?
Yep. Yep. We've got a long way. So as Schweitzer would say, it's a journey, not a destination. We've got a lot of work left to do. We've got a long way to go still. And again, if there was a close collaboration with the community members before the study even got started, if the community identified this, hey, this is a priority for us, this is something that's really important for us, and we want to address. And if that had all been laid out in the communication and the back and forth about, okay, how are we going to do this? Would it be the case that first of all, the community would be much less likely to tolerate non-feedback, right? Because if I identify, hey, this is really important to me, like I want to deal with this, and then so I partner with, so we call that detrimental reliance in the medical profession, right? So I'm a patient, I come to you, you're a physician, I seek your help because you are a professional and you have expertise, and you agree to help me. Now I am relying on you for assistance to my detriment. And that's actually in legal, that's a contract, right? And so now if you in North America would say, if you do not provide that help to me, that means we've had a breach of contract to my detrimental reliance. And so if you got a situation where a community comes to a researcher and says, we really want to address this, and research says, sure, let's do that, I can help you with that, and then there's no feedback, the community is probably going to say, wait a second, hello, you said you would help us and you would. So I think there's a much less risk, though not zero risk, that the team would not provide that feedback to the community.
Yeah, I see what you're saying.
I see Hannah Flavia.
Yeah, just want to know, how have you had any situation where you had to navigate with genetic research, and how were you able to overcome that?
Yeah, great question. We have not carried out genetic studies to date. And that is a real challenge. There's all sorts of additional potential ethical issues to address. We have collected biological samples. We do have biological samples that are banked. We do have in our consent forms, participants either agree or disagree for their biological sample to be banked beyond the initial study for potential analysis in the future with the identified data. But we have not crossed that bridge yet. So I can't personally speak about it.
I can give an example. I worked in a place where we were collecting samples to do HIV linkage to kind of see kind of which folks had similar strains of HIV. And it was a real problem. That study took about 3 years in the IRB, local IRB, because it was said that it was kind of like the implications of where the data would go, like are they gonna use this information to kind of target people? Well, you gave this person HIV, it came from you, and now it's like the same strain you have is all over the community. So it was more about the data breach than anything else. And because we were most of the people working in the community, they know each other for generations, and so even the folks who are going to be collecting and analyzing this type of data would know somebody connected to that information, even though obviously there's not supposed to say anything, but that's not how it always works. But yeah, it's and then most of the time they were saying that a lot of the community members are not going to understand the linkage part, and they're going to try to use this for criminal purposes. So yes, so that's at least like that was my experience with that. We never got
thank
approval
you.
for that. Actually, we were told to do something completely different.
Oh, thank you. Yeah, I understand that that happened even where I come from in Uganda when it came to HIV, but finally they got approval, but it was a long battle. I am part of an ethics committee in Uganda. Why I ask this is because one of the things we've been grappling with is first of all that the country guided research guidance sort of doesn't. It is there's been issues and they're trying to update it, but it doesn't come out clearly about genetic research. So I just want to learn from other areas, and maybe if at all have an opportunity to advise research ethics back home, maybe. So it's just a learning. I just want it for learning purposes. Yes, I need to share. Thank you.
Yeah, thank you for sharing that. Yeah, and good for you for realizing, okay, this is something that, needs to be addressed back home. And so seeking, okay, how do I get the information that I'm going to need to actually be able to meaningfully contribute to that conversation, to that policy development, which is super important. And that goes right back to our point about it's about building research capacity, but it's also about building the ethics capacity to oversee the research and to protect the community when outsiders are coming in to carry out those studies. Great conversation. Thank you.
If you don't have any more comments or questions, we will go ahead and bring this presentation to a close. On behalf of the Global Health Institute and MESCOP Global Health Programs, thank you, Dr. Proctor, for your thoughtful presentation and for your commitment to global health. And to our audience, thank you for joining us. Please look to our website for upcoming lecture information and past recordings. And Dr. Randall, we hope to welcome you on campus or via Zoom again. Our student groups and the GHI would love to host you for additional chats and talks. Thank you all. Have a great afternoon.
Thank you all. It's been a pleasure.
Bye. Thank you.